Uh, yeah. Thank you all. I'm privileged to be inside the chat room with all you people. I think Dr. Himadri Pathak, Dr. Debashish Banerjee, Dr. Deepak Shah are there inside, and we have Mr. Choton, Mr. Saurav, Mr. Ankit Kumar, and IT team with me. So fine, I think I didn't get any presentation from your side, Mr. Choton. I was expecting a presentation because the first thing that the IT team told me to ask, are you having a presentation or not? The okay, fine. I think we'll be talking basically on overactive bladder and the relevance of the mirabegron solifenacin combination. I think this is a new kid on the block, as we're expecting more of these new drugs to come in our armamentarium. So see, I think we have a lot of people like Himadrida, Dr. Devashish Banerjee inside the room, and who will be treating more overactive bladder patients than me. Okay, so I will like them to share their experiences as we go along. Since I don't have a presentation as such, so I will be actually making this presentation in the form of stories. In the form of stories, let's say, uh, like give a patient history and how he's treated and what will be the next course of action. Because then you can relate to these patient stories and you understand where lies the importance of this mirabegron as the mirbegas as we are all promoting this medicine. Now, we normally get elderly male patients. So can we just pardon me for the slight lapse. So we all normally get elderly patients with prosthetic issues, and the most of these patients have obstructive symptoms, and they have also an element of irritative flux. Now, what we know from our textbook teaching is we don't talk about prostatism in our history taking, nor we talk about obstructive voiding. We take about the different clinical parameters of LATS or the lower unit tract symptoms. So these in the form of obstructive symptoms. The most frequently are the slow stream on obstructed voiding and strain to void. And the most important thing is the irritative LATS, which is in the form of nocturia, urgency, and frequency. So herein lies the proper definition of an overactive bladder, which is basically includes the pointers of frequency, that is the increased number of times the patient needs to go to the toilet to pee, and urgency, that is the irrepressible urge to pass urination, often associated with a leak, which is known as the urge incontinence, and nocturia, that is when the patient goes to sleep after dinner and then he gets awake. Then he gets awake by the sensation to pass urine. So his sleep cycle is disturbed. He gets up in the night, he passes urine, and then again he falls asleep. Then again, once again during the sleep cycle, he is awakened by this urge to urine. So if he needs to get up during the night more than once to urinate, pass urine at night, so that his sleep cycle is disturbed, is known as nocturia. We are getting more patients today with symptoms of irritating LUTs, okay, plus minus obstructive voiding. Now, herein comes the crux of the problem, that these patients have an obstructive prostate. Then we basically take a proper history taking, do a proper examination. We see that the uroflow is obstructed, and after the blood test, I'm not talking about the blood test, just in gist, that the uroflow is obstructed. He has a 60-gram prostate with say about 100 cc residual urine volume, and is bothered by his irritative flats than his obstructive symptoms. So obviously, in these cases, you have to start him on an alpha blocker of your choice, and you have also need to treat his overactive symptoms as well. So often it has been seen that alpha blockers like tamsulosin and silodosin, does have an effect on the detrusor as well, though they mostly are working on the alpha receptors on the prostatic epithelium and on but they do have a role of controlling nocturia, and they do have a minor role in controlling the overactive detrusor. But in this case, you have to put him in on combination therapy with the anti-muscarinics. That's what we normally used. But the problem with anti-muscarinics is that anti-muscarinic will again cause relaxation of the bladder mucosa, and it will lead to retention of the urine. So ultimately, these patients, these elderly gentlemen, do have their overactive symptoms like urgency and urge incontinence taken care of, but he lands up into retention. That's the biggest issue that these patients are having. So in this case comes the role of mirabegron. And the problem with mirabegron is, I have seen, that is my because I don't have a presentation as such, and I can't show you all these evidence-based studies. So should have been evidence-based. All presentation must be evidence-based, I presume, and I do expect. But since we are talking with August gathering of number of urologists, then it is a issue that we find that these patients, we treat him with mirabegron on the first say. We start with mirabegron 50 milligram, and after some time, the mirabegron doesn't basically act well. For the first 1 or 2 years, the patient were having a wonderful amelioration of symptoms. Then after some time, the patients have recurrence of symptoms. So in these cases, we have adding an antimuscarinic. Then either we go for antimuscarinics as a different, separate from you when you are giving mirabegron, but to increase patient compliance, we now try to add a solifenacin 5 milligram. 10 milligram is too much of to start with. 5 milligram with the mirabegron 50s 50. That is the mirabegron 50s we're talking about. So herein lies the most important importance of mirabegron 50s in the treatment of elderly individuals with prostate issues with LUTS presenting to your clinic. Now, often it has been seen that the number of urgency episodes, the number of leaks have been diminished with adding mirabegron. And after adding the solifenacin with 5 milligram with, because solifenacin 5 milligram is a low dose to start with, because we normally give solifenacin 10 milligram, but solifenacin 5 milligram vis-a-vis 10 milligram, as because it is having less potency, it also will having less side effects. The most important side effects of solifenacin being dry mouth. All these antimuscarinics have high incidences of dry mouth. So these patients have been found to have less incidence of dry mouth when we are combining solifenacin 5 milligram with the mirabegron 50, always already on mirabegron 50, and these patients are doing well. So this is the story number one, or you can see the patient profile number one: an elderly gentleman with prostatic issues, very common, presenting more with irritative LUTS than with obstructive LUTS. You have to judge with your own surgical with own physician with your own acumen that these patients need amelioration of his symptoms, of his obstructive symptoms plus his irritative symptoms. You cannot give him you can give him, start him with alpha blockers, but again you need to give him something for the bladder. And as I repeatedly say, that antimuscarinics often leads to retention. In these cases, we are adding mirabegron, and as the story goes, with time the person becomes you can say, I don't know what is the term known as, but he becomes adjusted to mirabegron. So with ultimately time we will have recurrence of the symptoms, and then we have to add him solifenacin 5 milligram. So this is one scenario we talked about, ultimately doing well. But then this is a symptom, this is a person, we see him upfront, okay, but most of the patients we don't see upfront. We have a patient of 40-year-old male gentleman who comes to us in our outpatient clinic. He's saying that, Dr. Saab, I have this problem of whenever I go out doing marketing or whatever in the morning, and when I just come back and I just trying to open my door, the bolt of my door, try to unbolt my door, I have this sudden urge to urinate, which I sometimes cannot control. And often it happens that when I open the door and just get inside, some drops of urine just leaks into my pants, and becomes very embarrassing when I have people all around me. It also happens when I take now because of the lockdown period, not much of trains are running, but lockdown is easing out in Calcutta, as we can know for the last 2 days. So lots of crowded buses and trains. But when I travel by train, when I go to Shialda station and to catch a train, I often gets this panicky attack that I need to pass urine, and often I miss a train because I believe because there is no loose inside this EMUs, then I may leak some amount of urine. Now these patients are very common in your practice, and the best thing I actually tell them to do is do pelvic muscle floor training. Right. I think there is a two types of Kegel exercise that we know of. I think there are many people inside the room who are more learned than me. And I have already Dr. Surojit Das, Dr. Rana, Dr. Dulal, Kanti, and Dr. Mohapatro, Dr. Shoshim Kormuka, and obviously our own beloved Himadrida. So they will be knowing better than me that we have two type of exercises for pelvic muscle relaxation. And one is for the two types of Kegel exercise. Kegels is the gynecologist. He had told, he has blessed us with two types of exercises. One we talk about for the stress urinary incontinence, which is not the issue of topic today, which is not the topic of issue today. And the other is this pelvic floor muscle training for overactive bladder. If you take this person, 40-year-old male gentleman, he doesn't want to go into medicines directly. He tells, give me something, tell me something that I can control. He already gone to the Google. These people are very Google friendly. I told me, Doctor sir, what is the pelvic muscle floor training, or what is biofeedback? Now, I've seen patients coming back to me who says, I want biofeedback. Please tell me about biofeedback training directly, because they've seen in the Google, they talk this, so that they've typed something about how do I get relief from my urgency, my urine bladder leaks, and the first thing comes up is biofeedback training. Now the crux of the problem is you have to teach them. You have to teach them. First of all is the lifestyle modification. What is lifestyle modification? Obviously, one is you have to be active. Two is you have to avoid alcohol and smoking and all blah blah blah, all fana all addictions. And third is that you have to control your constipation. You have to be on a proper you can say plant based or whatever, fiber based diet. Now, these we all know. These we all know. But what is really the pelvic muscle floor training? We have read it in our Campbell textbooks. We often forget what is bladder floor training. Now, in Campbell textbook, this has been about a one paragraph or two paragraphs on pelvic muscle floor training. Now, they have done a lot of investigation. They have done shown pictures of electrodes been put in a patient's vagina, and doctors are putting fingers in vagina, looking at a contraction in the rectum, in the contraction, all these things. These are all too theoretical, and what is important is tell the patient whenever you have an urge to urinate, you have to control the urge for urination. It's simple as this. Okay. Now, what really happens is, as you can understand, the recent changes in in this pharmacophysiology and physiology of this overactive detrusor. Now, there's a concept of micro motions. I just read about it maybe a month back when I was supposed to teach a few of the students. So now I totally forgot, because all these things stay in your mind for a couple of days and they go just flush out. So there is a new concept of micro motions. Whatever it says that detrusor muscle, there are small micro motions or small action potentials being generated. And when this action potential is generated in multiple places, they then cause what is known as the abnormal detrusor contraction, which causes the leak. So it's the basic of the urge incontinence. So not all urgencies are urge incontinences. Right. As so, not all overactive bladders are detrusor overactivity, which is basically a urodynamic definition. So one is a urodynamic definition, the other is a clinical definition. So what is the point is that there will be small amount of tweaks or twitches in your bladder mucosa to start with. And if you let them increase in their severity, they will cause a major bladder contraction, which will cause an incontinence episode. As simple as that. This is the normal layman's way of teaching a patient. So you tell him, it has been written in the Campbell textbook. You tell him that thank you, Dr. Tas, thank you for the thumbs up sign. And if you have any question, you can always raise your hands. I will be more than happy to answer your questions. Well, not all questions can be answered by me, but I will try my best. And I find Dr. Eddie Sharma is also inside. Okay, fine, that's great. And so what really happens is, where was I? So I tell, so it's written that, and Dr. Gaurav, welcome inside the chat room. So what really happens is, if you tell the patient that you are in charge of yourself, it's not your bladder, you're in charge of yourself. You sit down in a chair, just like I'm sitting down in a chair, and you whatever do what we know from our Kegel exercise for SUI, or stress incontinence, is that we take in deep breaths, we try to hold the breath, and we then relax. And this has to be synchronized with your rectal sphincter contraction, because we don't have any voluntary control over our urinary sphincter. It's only a rectal sphincter by biofeedback mechanism, biofeedback loop, some biofeedback loop, that the urinary sphincter also gets activated. Now, it is not that you can say deliberate relaxation and contraction like a pranayam you do. It's basically quick fixes of your rectal sphincter. You don't have to go for elongated things like take your deep breaths and synchronize your rectal sphincter contraction. You just need to contract your rectal sphincter. That's all. Just go on contracting your rectal sphincter. It has been seen by just by contracting, holding the contract, and then contracting again. It has some biofeedback effect, which will go with which the bladder contraction will go off. Right? Bladder contraction will go off. It is more common. You may have a patient of an elderly female lady who will tell you the doctor Sam, I was very well for the few days, but for the last 3 months, I'm finding that I'm a diabetic also, and I'm finding that and my sugar control has not been of late very good, because I'm binging upon this of this delicious mangoes from Malda that what my nephew has brought. So often happens is that at the night when I go to the loo, when I go to urinate, just before I enter, just before I enter, you cross over your this thing, your door of your. Hi, Dr. Nilanjan, how are you? So we have lots of people inside. Some are coming and then listen to me, and some are going back. Great to be here. So so what really happens is, when I cross the before I cross the toilet door, I leak a few drops of urine, and then I go back. So herein lies the pelvic floor muscle training, the importance of pelvic floor muscle. You have to teach them that whenever you have this urge, you have to control your contraction yourself and not let your bladder take control of you. You have to sit. You have to sit like that. Start your contractions, contracting your rectal sphincter on a basically just go on fast twitching of your rectal sphincter. It will go off. Then you get up and understand whether the contraction has gone off or not. After that, then you go to the toilet to pee. It's not that you are deliberately delaying your urination. Yes, you have an urge to urinate, that means your bladder must be full, but you're having this sensation before that. Often what happens is these people will have this will have a urge to urination, and when they go to pee, they will be just peeing about spurts of urine, like just a few ml of urine. Nothing happens. He says, no, I'm getting pain, I'm going 50 times. We'll have this patients in your practice. We'll have patients like, I've lost my interest in my life, in my job, in my family life, everything, because I have my best friend is my loo. My best friend is my restroom. I go that about 50 times a day, about 10 times an hour. But when I go, I am not able to pee. Okay, that's very simple, because how much are you going to pee throughout the day? So that's a very important thing. Most of these patients do have some psychotic problems. They may have polydipsia issues, polyuria issues, but I'm not talking about them. For these patients, very important lies the importance of mirabegron. Okay, you start her on mirabegron, start him on mirabegron, and you see the results. Now, the problem with this antimuscarinics, when the patient is not at all obstructed, these patients are not obstructed. You see his uroflow, see her uroflow, they're supervoidals. Okay, they will have Qmax of 40, 50. And often one of the curves will go across outside your sheets, A4 sheets of paper where you have this uroflowmetry curves. But you don't. But when you give them these people, these are finicky people, you give them antimuscarinics, they will definitely say that, no, I've gone into constipation. What doctors have you given me? I've started this bladder bowel issues. Okay, I need to stop my medicine. Okay, or I have a dry mouth, or somebody tells me a horror story, or somebody tells me a dard wale kahani, or I can cry. all these stupid answers they will tell you. Now the problem is the anti-muscarinics is they will give you a good result to begin with, but the patients are not very compliant. This because the side effects come, they have a dry mouth most of the time and they're not compliant. To start them on mirabegron, actually is fact. Whatever I have limited experience, I have found the mirabegron works wonders. If you start with 50 milligram, 25 milligram is more of a placebo dose, I believe, but you can give 25 milligram for elderly where you want to go slow. And after some, you will definitely find that these patients are not responding. Then lies you add a solifenacin along with it. So solifenacin 5 milligram with a mirabegron 50 is always a second line treatment. Don't give it a first line treatment. Okay, because the first line is the biofeedback, or first line is the lifestyle modification. I told you about all these things, fluid restrictions and all, and for nocturias, you just cut down on your fluid intake and beverage intake, and cut down on your caffeine intake and all these things. Then is you do a biofeedback mechanism, all the pelvic muscle floor training. In fact, people do say that you do the lower muscle training like yoga and all these yogi exercises. Then you go for these medicines, right? Start him on or her on mirabegron. And if he has a correspondingly obstructed in the uroflow, you can put him on alpha blockers as well. Alpha blockers takes his own course. Let these bladder relaxants take their own course. In child, that's my normal use is obviously is I use oxybutylene to start with. I've never used mirabegron, and I hardly, rather than tolterodine, I hardly use any other medicine. So I never used solifenacin because that's my point of view. That's my, I can say, the level 4 evidence, but you will be more better known. I don't have a, again I say, I don't have a this thing. I don't have a presentation to give you an evidence-based presentation. So that's it. And about any complications of mirabegron, I rarely found any complications of mirabegron. The only thing is in literature is hypertension, but I think I never come across a patient who had stopped mirabegron because of hypertensive issues. And that's it. I think this mirabegron 50 milligram with the solifenacin, we hope that it will increase our patient tolerance and compliance as also, and the patient, because these patients, no, we don't know what to give. The obstructive symptoms, the irritative labs, we can give the concept of, we can give the option of surgery. But these patients, even though we tell them, even if you undergo surgery, some amount of irritative symptoms will be left behind, and it will be controlled with due time. But the problem is with these patients, so with overactive detrusor, so we don't have any this thing obstructive symptoms. So what surgery do we give? Obviously, next thing you can ask, you can tell me is injection. This thing. What they say? I just forgot the name. Botox. Yes, Botox injection. So, but I don't have any personal experience of Botox injection. There will be people inside the room, I think they have their personal experience of Botox injections. So you can always share your views on this. But after that, then all this small bladders, thimble bladders, augmentation cystoplasties, everything becomes a real heck of a problem. So the more we treat him with medicines, the more we treat him with pelvic muscle flow, exercise, lifestyle modification, the better for us. So if we are done, I think I'm done with my talk. So if you have any question, you can write on the chat. You can write on the chat section, or we will call it a day. I think we had a lot of learned fellows, or many of my seniors and my colleagues are in the room. I was very blessed to have them in my room. I think I didn't board them for too long, though many of them came in and went out. So I think thank you, Mr. Chodron, for allowing me to be with all of you together. And thank you all. I don't think any questions in any question in the chat, I think, isn't it? Someone, can you unmute and just say that whether we have any? I can't find the chat section right now because this Zoom thing, I always get lost. I don't find a chat section when I share screen or whatever. So okay, thank you, gentlemen, for being with me. And yes, IT team, you can unmute yourself and
yes, sir.
Okay, so we are done. Thank you, everybody. So we'll come later and see you again. Bye bye.
Thank you, sir.